We know that the sodium is largely filtered and reabsorbed at the proximal tubule, around 97%. Then around 1% or 2% is only excreted, and around 2% is absorbed at the level of the collecting duct using the epithelial sodium chloride channel, which takes out sodium along with chloride. Sodium is quick to go out, chloride is slow to go out, so there is an electronegative environment in the lumen which allows the positive ions like potassium, proton, magnesium, calcium to go out. Now, this epithelial sodium chloride channel is regulated via the aldosterone largely using the mineralocorticoid receptor. And as I said, chloride comes in slowly. So that's why potassium can go out, proton can go out, magnesium can go out, and calcium can go out. So anybody who has got more absorption of sodium will have a loss of proton and potassium. So hypernatremia will be associated with hypokalemia and alkalosis. Other way to think of it, if you want to excrete potassium, you need to have a sodium to exchange with. So if you have hyperkalemia, you will compete with proton and you will jump into the lumen, not allowing the proton to go out. So hyperkalemia will therefore cause metabolic acidosis. The other way around, if you have metabolic acidosis, you will have hyperkalemia. Now, kidneys, of course, we know the juxtaglomerular apparatus produces renin in response to potassium and volume, which converts angiotensinogen to angiotensin 1, which is converted via the ACE enzyme into angiotensin 2, which is one of the most important factors. What are the three major functions of ANG2?
One is ANG2 converts to aldosterone, so it will be
stimulates the production of aldosterone.
ANG2 also causes the vasoconstriction, so it increases the blood pressure.
Yes.
It has a stimulatory effect in the thirst.
So it is basically increasing your water, increasing your sodium, and increasing your BP. Three major effects are there from the ANG2 which is there. So BP, thirst, and adrenal. These things are there. Now, aldosterone, we have said, is largely regulated by the renin-angiotensin axis. There are other effects as well. It's not that the other factors do not control it. ACTH does it partially, but not majorly. AVP does it also. So whenever you have mechanisms, you say, okay, now AVP goes up with stress, hypovolemia. It would also have some push as far as aldosterone is concerned. It is inhibited via the ANP. And this is extremely important when I talked about SIADH. In SIADH, your atrial natriuretic peptide is high because volume is more. And this ANP is inhibiting aldosterone. Why is it important for ANP to inhibit aldosterone?
So sodium, there will be sodium loss, sir.
Because if you have aldosterone, one hand you are losing and one hand you are conserving. So the first mechanism is to switch off. So it will switch off it's an antagonistic hormone to aldosterone. Other agents are dopamine, which also inhibits aldosterone. So dopamine may cause diuresis rarely, and that's why people used to use it in a renal dose, so-called renal dose. And somatostatin is also inhibitory. Now, cortisol plays an important role here by binding to the epithelial, to the mineralocorticoid receptor. So if you have too much cortisol, as we discussed in the setting of somebody who has got 11 beta HSD problem or somebody who has got hypercortisolism because of a high ACTH, you will have hypertension. So 11 beta HSD2 prevents the binding of cortisol to mineralocorticoid by converting it into cortisone. That is the classical scenario we talked about, AME, in terms of management. Now, aldosterone secretion is largely, as I said, regulated via the angiotensin 2, via the angiotensin 2 receptor. But as Dr. Alapan was talking about, potassium also has a direct influence in that regards. Some effect of ACTH, ANP, dopamine, and somatostatin are inhibitory pathways in that regards. Aldosterone, so ANG2 basically acts via the phospholipase C, allowing the calcium to enter, which is then going to increase the production of CYP11B12, which is basically the 11 hydroxylase to produce aldosterone, aldosterone synthase to produce aldosterone in that regards. This pathway becomes important when we talk about primary hyperaldosteronism, and many genes are there which can cause increased aldosterone production. Potassium also has an important role. There is mild effects of ACTH via the MCR, and this becomes important. So ACTH has a major effect on which part of aldosterone? Dr. Sandeep had talked earlier. So I said angiotensin 2 increases aldosterone production. ACTH increases
Aldosterone production.
release. So it's mainly the release, not the production. Now aldosterone, what does aldosterone do?
It absorbs sodium and excrete potassium.
Okay, this is the final effect, but what is its main effect? What does aldosterone do? What does vitamin D do? What does ADH do?
In
So it increases the permeability of the collecting duct to water. Vitamin D increases the permeability of the intestine to calcium. And aldosterone increases the permeability of the collecting duct to sodium through calcium binding protein, through aquaporin 2, through an ENaC channel. So basically, the effect of aldosterone is only to push the already present epithelial sodium chloride channel to the membrane. So what it does, it binds to the cytoplasmic receptor, goes to the nuclei, expresses, and of course from here, this is something which we discussed about cortisol and 11 beta HSG2, and this ENaC basically then gets expressed in the cell membrane. So if you have got more aldosterone, more ENaC, more sodium absorbed. What does it mean? If you do not take any sodium, will aldosterone help you?
no.
Because you need sodium, and that is why in infants with CAH, we always say you give them salt. If you don't give them salt, they will have no absorption there from that perspective. Yeah. And this sodium is then absorbed from there, and then it is pushed from the basolateral membrane using the sodium potassium channel, which we have discussed already. So aldosterone is a very interesting hormone. The levels are low, but then they go up very high, and then they drop down subsequently from that perspective. So around day 7 or so, your levels may be pretty high as compared to a adult individual, and that's why the fludrocortisone requirement may be very, very high in CAH, especially in the initial phase to go on to from that perspective. So requirement will be high, but as somebody ages and they have enough salt intake, the requirement may come down. So some patients with CAH, we may be able to wean off fludrocortisone subsequently because of this perspective. So, Dr. Vibha, 2-month-old child with failure to thrive, sodium is 142, potassium is 2.8. There is high blood pressure for the age. Renin is undetectable, aldosterone is undetectable. What are you thinking of?
Could be 11 beta HSG2.
Okay, so you have to think of a DOC defect. So you will like to look at the genitalia.
What is?
So genitalia is normal and it's a normal. This becomes important. So it's a normal female. So then in that scenario, you have to think of a possibility of an apparent melanocorticoid excess as well, which can present like that scenario. 14-year-old girl with DSD, there is hyponatremia, hyperkalemia, 17 OHP is very high, hydrocortisone 20, fludrocortisone 0.2. Still the potassium is high. This is similar to the case whom we managed recently. Despite this dose, she was having hyperkalemia. What is the possible cause?
First is we have to check for the adherence, whether the child is taking or not the medicine.
Mother is giving.
Then we have to give the salt in this case also.
So salt deficiency could be there, or your requirement may also be high. Sometimes I have gone up to 0.3, 0.4 also rarely. So this could be that the requirement is high, and you very nicely said salt also can be deficient. Final word on adrenal androgens, which we know are basically DHEAS, which is produced around 15 milligram per day. DHEA is a smaller one, and androstenedione is extremely low. The important feature of adrenal androgens is that they are more estrogenic as compared to the testicular androgens. What does it mean and what is its significance?
Sir, the significance is at the onset of puberty, sir, when there is adrenergic, gonadarchic disconnect is there. So the pubertal gynecomastia happens, sir.
Yes. So if your adrenal is producing most of your androgens, you will develop gynecomastia. Classical example is in the neonatal period, in elderly, and during puberty. If somebody has CAH, That also can cause gynecomastia because adrenal androgens are much more estrogenic as compared to the testicular androgens. This is something to remember from that regards. And it also produces a very, very small amount of testosterone. This is what we are talking about, Alapan, when we were discussing. So it's only a very minimal amount of testosterone. So most of it is there. 50% of female androgens are produced via the adrenals.